You're listening to Streetside, a Street Medicine Institute podcast.
Welcome to Streetside, conversations at the intersection of health, homelessness, and humanity. I'm your host, Poyani Bavishi, and today I am honored to be joined by Dr. Charles Zhang, emergency medicine physician in Chicago and the clinical director of Street Medicine Institute. Welcome, Charles.
Awesome. Thank you for having me.
Yeah, thank you so much for joining. Typically, we start off by having people tell us a little bit about yourself and where you're from and how you got started in street medicine.
So I'm from Chicago. I went to med school down in New Orleans. When I was in med school, I did a double degree in medicine and public health. And I think my second or third year, Dr. Jim Withers came to our class and was telling us about street medicine. And, I went to Tulane for med school, and I had gone to Tulane mainly because they spoke quite a bit about social justice and working with vulnerable populations. And when Jim came in and talked to us, there was a part of me that just went, oh, this is something I need to do. There wasn't really much more logic to it. So from there, I think when I was a fourth year, I rotated with Operation Safety Net in Pittsburgh. And then, he had me sold on this whole model. So when I did my residency in emergency medicine, I stayed in New Orleans. I did it with LSU. I'm also very big into social justice and working vulnerable populations, which is really awesome. And it was there that I created a street medicine program in New Orleans. It's at that point we didn't really have one. And I got to work with some really cool people. It was actually a good place to start a smaller program because the city isn't that big. Pretty quickly, the students from both schools joined on, created some awesome projects. I think they're still carrying on the work. And then when I left, I came back to Chicago. And here in Chicago, I'm working in emergency medicine, but I've been pretty involved in street medicine, both as a clinician, volunteering with some of the nonprofit organizations, providing care, but also for the last couple of years as a board member for Chicago Street Medicine, which is a nonprofit that kind of helps support multiple medical student chapters here in the city. This past fall, I got hired to do this cool job. So now, I get to meet lots of cool people everywhere, get to talk with them, connect people, help them. It's been great so far.
It's certainly been exciting to see the direction that you're taking things with the Street Medicine Institute. I'm curious, when you were in medical school, did your exposure to street medicine affect the residency that you chose or the specialty that you chose?
Maybe partially, but not really. I was between family medicine and emergency medicine, I think, when I was going into residency, but they were both generalists, relatively, like broad knowledge and not necessarily specialists in that sense. But I kind of knew that I wanted to work with vulnerable populations. And what it really came down to, I think, was my personality and what kind of work I was looking for in that moment. And that's how I landed on emergency medicine. But I knew, in that moment, the concept of street medicine and kind of going outside of backpacks was really just not a thing that was considered. So it wasn't really something that I ever considered as a career or something that my specialty would factor into it, because I figured it was always going to be an other thing, plus thing to what I'm already doing. So in that sense, it didn't, but it kind of aligned with what I was really hoping to do. And something that I like about emergency medicine is that, here in the United States, it's pretty much about as low barrier as it can get for someone to access. We're open 24/7. You're not going to be denied at the door because you don't have the right payment or the right insurance. Once you get there, the health costs can be gnarly depending on where it is and all such sorts of stuff. But at least in getting in, really one of the few places where our population of people who are unsheltered can get timely care. So that part I do like, that how it aligned with street medicine and that we often overlap in caring for this population.
Absolutely. It seems like your values aligned with both street medicine and emergency medicine in similar ways. And I feel like some of the most exciting endeavors are ones that we don't necessarily anticipate. So it's really cool that you were able to explore different ways to get involved with street medicine.
Yeah. And, in LSU, the aspects of social justice and working vulnerable populations is pretty big, but also part of it in emergency medicine, we're also starting to see more and more of it. I think when I was a resident was when the first social emergency medicine interest group started with the big national EM organizations, and also in healthcare education, where we really started to put more weight into the social determinants and how these other aspects affect our care in the emergency room and kind of our role in it. good. So I think the timing was good. I had an interest in working with a population where these factors play a huge role, these environments and other societal factors. And at the same time, emergency rooms and especially the program that I was in, this was also an increasing factor that we were kind of taught to recognize as we're providing care. So the timing was good.
And I know you're passionate about medical education, and something that I've been thinking about is that, for many, social determinants of health were introduced as we were moving along in our careers. Whereas now I feel like medical schools really are introducing the social determinants of health quite early on, which is great. And I feel like it's lending for deeper conversations within residencies and within clinical training programs that people are maybe starting from a place of more shared understanding.
Yeah, and I think medical, really, we can say like medical school and residency, but probably true for a lot of the other healthcare educational places. The foundation that you're taught, a lot of that education can come from books, but also comes from those that you learn from and idolize, and you kind of practice off of their practice habits. There are parts of our healthcare system that just does not address care for people who aren't unsheltered very well, and our patients, unfortunately, when you talk to them regularly, you'll hear it. They face a lot of stigma and discrimination. They face a lot of barriers, and a bunch of this is just carried through from how you were taught and how you kind of accept it as this is the way things are done, and it becomes kind of solid, and then it becomes very hard to change once you leave the educational space. So, I think it's important that we work with students kind of at the beginning, where they kind of really recognize how important all these aspects are to the health of all of our patients. Really, this is true for all of our patients, not just patients who are unsheltered, and have that be incorporated as the foundation. So with that, when they leave and become, the attendings wherever they are, or the soul health clinician wherever they are, they include this and not kind of carry on traditional practices that haven't been as good, especially for our population.
It certainly sounds like that was part of your journey, going to Operation Safety Net and then starting a new team down south. What was the experience like of starting a whole new street medicine team?
Yeah, what I gained the most, I think I probably gained quite a many things, but one nice thing that I hold on to, that the month that I spent in Pittsburgh with Safety Net, I spent that month listening, and I think when you're a student practicing in the healthcare setting, kind of getting used to our healthcare system and all of its factors and time limits and rules and all these things, you really don't have that much of a time to really listen to the people. And the challenges being faced by our patients who are unsheltered are so complicated and so diverse and varying, very easy to assume and kind of think you've seen one and they're all bad or whatever in this way or another way, and then kind of carry it with you. So I really just spent that month really listening to a lot of people and recognizing, they're just people like any of the other patients that we have, and all the reasons that they are where they are now and what they hope for, and how it's not me having to tell them what to do. That this is a place where I truly can just be a supportive role and a positive role for them, and not have to do things how things were before when they really weren't working. Down in New Orleans, when I was starting my program, what we tell folks who are trying to start out, you really start with that needs assessment. Building a street medicine program, it's meant to be a part of the safety net. It's meant to figure out where the holes are, where the biggest need is for your population. It's meant to be, patient-led, community-led, letting them kind of guide what kind of shape and form the street medicine program will take. So that first year, I mean, part of it, I was a resident. I'm not ready to go out and see people on my own, But part of it is also that I didn't have the greatest idea of what was needed in New Orleans. And New Orleans was an interesting, I don't know if interesting is the right word, but it was a place where it's been a while after Hurricane Katrina, but it's still very much, a community trauma for the people that live there. The city is shrunk by a lot, so there are quite a lot of abandoned houses, especially in the impoverished sides of the city, where all the rebuilding, all that stuff wasn't happening. So you had like a sizable population of people that were living in sheltered in abandoned houses, because they were all just there, along with all the unsafe conditions that come with those. So it had specific aspects, that's different from maybe some of the other cities where you have people who are experiencing homelessness. So I really just spent that year trying to find all the organizations, kind of attending their meetings, introducing myself, telling them this is something I'm doing, kind of figuring out what they felt they needed. And out of those, I had two really awesome partners. I met someone named BB St. Roman, who was hired by the police department, but is not an officer, and her whole role is they gave her a van and she knows everybody. She drives people around, gets them to the care that they needed, and everyone knows her. So she kind of became the liaison for me. She became someone that could help bridge that barrier and tell others that, you can work with this person. He's not going to be the same, like maybe the bad experiences you've had before. And secondarily, I got to work with someone named Robin Birchfield, who worked with New Orleans EMS. She was also, I believe, a nurse and a social worker, and kind of her role was in advocating for the patients that were high utilizers of the EMS system, and a lot of these were also people that were unsheltered. So we kind of started there, and then pretty quickly, I think I had a student from LSU down in New Orleans, then a student from Tulane, and then very quickly became many students. Then we had groups from a Catholic charities group called Health Guardians that were kind of an intensive case management group that were doing awesome work. And it just kind of built on and on every year, as we recognized the need that was out there, I suppose. But I think it was more helpful in that sense for me. Street medicine programs, they're built based on what's needed in the community, but they're also built on the capabilities of the program. Not all programs can start with millions of dollars in funding, all that staff. And I was starting with, myself and my car and my backpack, my computer in my living room, that was my EMR system, a locked cabinet behind a closed door to be my record system. I was building something that I was following the standard of care as best I could in that moment, but I was also quite limited. I didn't have a budget, I didn't have my own nonprofit status, any of those things. I just knew the work had to be done. So in that case, where I was most impactful was less like having the ability to have tons of medicines on me and to give it out to people, though that is a great service if you can do it, but more in being that connecting glue, that safety net between all these different services, recognizing the health needs, creating plan with those health needs that really helped that person specifically. And then be able to kind of follow them in their environment. Anyway, it was a very good experience. It was a lot of work, but I thoroughly enjoyed it.
It definitely sounds like it, especially in residency. That's incredible. And I often feel like there's such a range of street medicine programs. There's groups that have several interdisciplinary teams and can go out with a phlebotomist and are really well-rounded in that way. And then there's other teams that are primarily student-driven who might not have a attending or provider of that sort on the team, but are really serving as the glue. And I feel like it's so important to realize that that is really the foundation of the work, is just to go out and to be that person who's continuously checking up on people and connecting the community, even if it doesn't feel like you're maybe doing as much as other teams that you might see. But
Yeah. And
yeah.
I really did, like, maybe we started with one or two. I was actually looking through some pictures recently. We'd start with like one or two people who would go out, but then, as the years go by, we would usually have a couple students. We had members from like the downtown development district that would volunteer with us. A couple times we had people with lived experience. Having that multidisciplinary team and people with varying experiences and backgrounds really helped, I think, with the work, like you said. And I really do enjoy when we're out with the students and just letting the students hear from the people and talk to them. That's what as I had said earlier, I gained quite a lot of value being in Pittsburgh. So it's good that the students also had that opportunity to kind of be, we went out at night down in New Orleans. So I can like just picture the students kind of sitting with the people who are just sleeping out there. It's warm. People don't really do tents too much in New Orleans. And just getting to talk to them and hear what's going on and kind of hear how we can support them.
Yeah, and it also sounds like you were able to identify the key people in the community who also had, sounds like, really valuable experience doing the work already. And I'm curious, when you reflect on that time, what the biggest challenges were that you were facing when you were trying to start this initiative?
Yeah, as I was saying kind of a little bit, it was kind of just me. I knew the work was happening. And this was about 12 years ago, which is not that long ago, I guess, but it is a long ago. Street medicine then is a bit different from street medicine now. Street medicine now, there are programs in many medical schools. There's a place of service code where someone can bill for it. Back then it was a thing that was definitely happening. And street medicine, that like medical care where a person's at, I think has been around for a long, long time, all over. But there wasn't much. It was kind of like every time you have to start from scratch a little bit. I took all the stuff that Jim Withers taught me and also the other peer navigators and folks that I worked with over at Safety Net in Pittsburgh. But I was kind of operating, I think the main challenge was I was operating without that much support necessarily. Like folks, the other organizations understood the importance and wanted to be a partner and wanted to like collaborate. But past that, it was still just me. So that was probably, one of the bigger things there. I think of, the other part was certainly I was a resident at the same time as I was trying to run a program. And this was a program that I had that again was also kind of new, that the idea of it, especially to a lot of people. So current programs, I think student programs still have a lot of challenges, which I also did, was in being able to go out more often than we wanted to. It was limited based off of my schedule. Could try to go once a week, but I couldn't offer the same time once a week because I work in the ER. I was a resident in the ER, so my shifts were all over the place. I guess separate from some of the medical student run programs that I see now, where the medical students kind of recruit attendings, but the medical students are leading the run. The program when I was running it was very much, I think I went on every run. I'm not sure if we ever did any runs where I wasn't there. So I was kind of the sole clinician. There were times when we had an awesome doctor from Healthcare for the Homeless, Neil Nixdorf, who would come out and volunteer with me. So then there were like two of us, and at times we've had other clinicians come out. But generally, I think I was in all of them. So we were also limited in the fact that it was kind of, at the mercy of my ER schedule, my ER resident schedule, which can get a little nutty.
Yeah, that sounds incredibly challenging. And especially when you're meeting new people and trying to build that trust, I feel like the biggest things we have is to say, I'll be here at the same time next week, or at least a time that you can expect me. So that must have been, especially for a newer program starting, something that was pretty challenging to navigate, but it sounds like you were able to build and have people that were able to support you down the line too.
Yeah, and I feel like I'm like saying this over and over, but something that we tell our new programs, what Jim Withers has also said, that for a new program, don't go big and try to go promise too many things that you can't keep, because that worsens, you're trying to build trust and showing that you're a dependent program, or you're a program that someone can depend on. But if you're, saying you'll be there and then you're not there, that doesn't help. So at least I was small and I told people I was small. These are some things I can do. So we could set that expectation appropriately. And I could tell them, when I'm following, I will be here next week at this time, this day, could we try to meet at that time? And, they could tell me one way or the other. And what helped was that later, when we had more community partners and we got to work more with the other outreach organizations or the social work organizations, they were able to follow up on some things and continue following up, if we were helping them with housing or helping them with benefits. So they could keep that continued contact more often than just I could, through street medicine. And I think that is definitely a strength of street medicine programs, being a collaborator in that safety net. That feels like a definition of safety net.
Yeah, and it's interesting because it comes from such a well-meaning place to want to promise everything that you can think of for your clients. But I think that's something that you get used to very quickly, is knowing your limits and understanding how important your word is. I'm curious if there's other aspects of street medicine that maybe well-meaning providers may get wrong or struggle with earlier on or have to learn over time that you've seen.
Something I think about, one of the lessons that I learned in Pittsburgh, I was a medical student. I had worked with a patient that has seizure disorder, and I had gone out on street rounds, and they said, "Oh, I'm out of my Keppra," but I had Keppra in the backpack. So, well, at least that's what my memory from a long time ago says. I'm not sure now, but I think I had like enough maybe for a week's worth of Keppra, and then I said, "Well, we can send you the rest," or whatever it was. And then I encountered him, I think a week or 2 weeks later, not on street outreach. I think I was just out grabbing a burger with my friend or something. And I saw him and he's like, I don't have my Kepra. What am I going to do? And that moment I called Jim and I was like, I don't know what to do. This person doesn't have his Kepra. And I think that the lesson there, you want to help these people. And there's like you feel a drive to kind of do everything possible and like kind of go out of your way to do everything possible. Like what do I do? What do I do about this? And then, the downside to that is, you kind of forget you are also a person and you have limitations, right? And if you push yourself to that, like to that level with every person, you're gonna burn out. Maybe not, they talk about, compassion fatigue and all those things, which is true. Like seeing what happens with our people, it is hard, but also like pushing yourself and not getting good rest and all this stuff, you're not going to be able to sustain this for the long term, and I remember the advice I was given then is that, this patient is kind of sucky and we can try to do some things, he's also an adult, he's at the center, and we can support him. You're not babying him, you're not taking away his agency by trying to do this and do that all for him or something of that sort. And it kind of gave me a realization that there's a balance there to the work. I don't know if that makes sense, but that's kind of helped me quite a bit in figuring out, even outside of street medicine, just my general work-life balance. We do a lot of things and we push ourselves on a lot of things, but we also got to do it sustainably and give ourselves a break once in a while. It can't be on call 24/7 forever. That's not good for you.
Definitely. And I feel like it does speak to medicine in a greater sense. Is I'm sure you see this in the emergency room of people who, with, the frequent flyers, quote unquote, that you mentioned earlier, of just you might set someone up with a specific plan, but then they come back. And I'm sure that it can at times feel like, what's happening, that we can't get this person there. But especially when you're on street medicine and maybe when you're starting a program or when you're one of the only providers going out, it can feel like you're the person that's there going to people. And if you're not that person, like what's going to happen? And I think the sustainability piece is so important there, of taking care of yourself and having that be the way that you continue your work.
Yeah, and that really also builds on that point of street medicine being part of a safety net. I'm not the only person out there that can help this specific person. It's not like if I don't do something, that's it, and or like he's gonna have a seizure or something. I mean, I'm part of that network. But with other people in the network, other easier to access clinic spaces or other outreach teams, we can all work collaboratively to make sure that person has the medications, ways that he can prevent harm should he have a seizure. It's not just your one person. So excellent point that you brought up.
Thinking about like the broader safety net and how this network has grown over time, shifting gears a little bit to your work with SMI and serving in your role now, I'm curious how you help support different teams across the country and across the world, really, in terms of balancing this kind of like grassroots essence and energy that groups are bringing, and how that interfaces with SMI and your role.
Yeah. Street medicine now certainly has grown quite a bit since it was back then, but that doesn't mean that street medicine as it was done back then doesn't exist. Even I've been here maybe 4 months, and a lot of what we do in the support roles, I meet people and I answer questions and I kind of share, experiences that I have, or if I don't have those experiences, because I certainly don't know everything, I connect them with the right people that do. And I've met quite a few awesome people or communicated with them that are kind of starting out just like I was. They're in a place, it's someone that's a medic, a volunteer, that's going to be a student, trying to partner with one other person, and they recognize a need and they want to do street medicine and figure out how to do it. At the same time, we hear from organizations and we hear from medical schools that want to kind of do the same. So it's all there and it's all good. They need the same kind of support, that we were happy to give and build. And I think really a goal of this institute, as I understand it, is to build this collaboration. We talk about a safety net in the community, with the street medicine program being part of that safety net and connecting people and helping this person and patient navigate through our complex healthcare system, to their positive change. But we also want to build a like a safety net for all the programs. Some of our programs are in places where it's less friendly to do street medical care, or they're the only street medicine program, and there's not really much other support in terms of homelessness services, and it can be isolating. So we really want to make sure that we are in solidarity with each other, that we're all supporting each other for each other, because ultimately that's what's going to help the patients in each of these places.
And of course, we're more powerful when we're together than apart. When I was part of SMISC and serving as the student liaison, we started this program where we would connect different student groups across the country. And, I think people often found it really useful to talk about, like, how are you structuring financing your team, or sustainability with shifting students throughout different stages of their training. And over time, I think people really evolved to just kind of having these more like supportive conversations of like, wow, this, we just experiencing something really hard. And like, have you guys ever gone through that? And even if people haven't had the same experience, just having that like supportive ear to vent to, or to feel heard by a larger community, I think was really key. And of course, I think it's really progressed into larger things. Like you mentioned, there's a billing code now for street medicine, and these like larger advocacy initiatives that I think have also been like a testament to people uniting and finding other people doing the work too.
Really, shout out to all you students. The students created this podcast or started it, which is awesome. The students that I was working with in New Orleans, I wasn't even thinking about these things at that moment. Did like an internal hospital competition to build an inpatient consult service, and they won that competition and got it started where I was before I even got into harm reduction as I am now as an advocate. The students were participating in Tri-Stereo, the harm reduction organization in New Orleans, where it's much less friendly than it is here, and they were kind of already doing these awesome work. So it's quite awesome, and it is a joy of mine to get to work with these SMIS students, or really any medical students, to kind of include this as part of the education, like all that stuff we talked about earlier.
Definitely. I guess I'm curious for people who are listening right now, what you think that people could be doing to support street medicine on like a systemic level.
I guess for any person, support it in your own way. Some programs they could use funding help. Others, it's being understanding of the model and its place and being like a safety net, not have to feel like that they're either trying to replace the care that you're trying to receive, or that they are potentially worsening things, misconceptions about what street medicine is. I think everyone just, kind of I don't know, be neighbors. I don't know, just be good.
I love that. I mean, that's something that everyone can definitely work on in their individual and groups settings.
Yeah, and I probably also say, we street medicine is patient led, and I like to think, but certainly for me, creating these programs and thinking about these programs and supporting them, and also the care that I give, the people are in the center. So any of these things that we do, to support street medicine programs or support other programs, we gotta keep, these people in the center, kind of recognize and understand their challenges and continued challenges. So anything that we do that helps support them is good for street medicine, I think.
I'm curious if you have anything that you feel like we haven't touched on or shared in our time that you would like to add.
I mean, if I'm allowed to plug our
Always.
conference,
Always.
please consider coming to our symposium. It's the end of September. It's going to be in Halifax, in Canada. So we're very excited. These are, I remember the first couple conferences. Well, the one or two conferences I was able to make, I think as a resident, and they were just fantastic opportunities to both learn about street medicine, but really just meet a diverse group of people that are all awesome and kind of care about the kind of work that we do for the population. So if you're able to come, please come.
A great plug. Yes, and you will leave feeling energized and excited. And I think it's a great way to keep your work going, especially as once you make those connections with people at the conference, you really can carry them forward. And so Yes, absolutely. Go to our street medicine conference. And then we wrap up the episode for everyone with the same question, which is if you could do one thing to make the world a better place, what would it be?
Well, I don't know if we're considering plausible things I can do or not, but I think I'd like to hope to be an example on some sort or some sort of way. You know, the hospital work that I do or working with students, showing that there's a kinder way to work with people and to be with people where it doesn't have to have a lot of the current things that are happening in healthcare, and how it's not only good for the patients, but also good for you as a clinician, you know, or as a student. Being person-led and just being kind as a start, kind and open-minded as a start. If we can approach things from that angle, I think that will really help to make things better for everybody.
Absolutely. Be a good neighbor, like you said before. Yeah. Thank you so much, Charles, for joining and for your time today. It was great talking to you.
Yeah, no, thank you so much.
The Street Medicine Institute is a secular, nonpartisan organization. Any spiritual or political views shared by guests on Streetside are their own. They're offered in the spirit of conversation and should not be taken as reflecting the views or positions of the Street Medicine Institute. This podcast should not be used for personal medical guidance. Please consult your healthcare provider.